So thanks a lot. So my name's Dan Wootton. I'm a chest physician. I work up in the acute trusts in Liverpool, and I'm employed by the University of Liverpool as a senior clinical lecturer, research pneumonia. I've previously worked in Southern Africa and Malawi for a few years running clinical trials, and I'm currently funded through an NIHR Advanced Fellowship to study hospital-acquired pneumonia. And we're going to hear all kinds of fascinating data today about the implementation of new exciting technologies in different contexts. But I thought I'd start off with trying to be provocative and to offer what I hope is a disruptive talk that will invite us to reflect on the challenges of implementing these technologies if we are to stick with the current concepts that we have of lower respiratory tract infection and its various subcategories. Pneumonia continues to have a huge burden internationally, and in almost all circumstances where we treat a patient for pneumonia, where we make the diagnosis, the underlying etiological agent is not known. And so what we've evolved over the years are case-based clinical definitions that we hope delineate out groups of people who share similar etiological characteristics and similar prognostic characteristics to give us a fighting chance at trying to use appropriate empirical therapy at the point at which we treat patients. But what I'm going to try and suggest to you is that many of the underlying assumptions behind those categorizations are weak and are going to be increasingly challenged by technologies like the likes of which we're going to hear about today. So I think our current definitions, even of pneumonia, are of limited practical use. The British Thoracic Society define a case of pneumonia as someone who has symptoms consistent with a lower respiratory tract infection, so someone who presents with cough or worsening cough or new sputum production and shortness of breath, and has symptoms of a systemic inflammatory response. So they might have symptoms of a fever or a demonstrable pyrexia or some kind of biochemical surrogate for systemic inflammation, like a raised procalcitonin or a raised CRP. And if you have that set of symptoms, and when a physician listens to your chest, they find clinical signs which are consistent with a lower respiratory tract infection, then you can manage the patient as per the BTS's pneumonia guidelines that are applicable in primary care. And you can be coded as a case of pneumonia. However, even before the COVID pandemic, if you do surveys of GPs, they very rarely invoke the diagnosis of pneumonia. They don't use the diagnosis, they don't find it useful, despite the fact that the BTS guidelines back in 2009 suggest that 70% of community-acquired pneumonia is treated in primary care. Post-pandemic, a very large proportion of GP consultations in the UK are now conducted virtually. So they're either conducted via video conference or over the telephone, where it's not possible to measure a patient's temperature, and it's definitely not possible to listen to the chest. And so these existing case-based definitions of what pneumonia is in a primary care setting, even if GPs decided that they like them, which they don't, can't be applied in current practice. But do these matter at all, and why do they exist? Well, I think the reason that we delineated out a group of people who have pneumonic disease as opposed to a non-pneumonic lower respiratory tract infection is because of assumptions about the underlying pathogens. It was felt, I guess, that people who have changes on their X-ray reflective of deep lower airway inflammation and alveolar infiltrates, that must be caused by a different spectrum of pathogens to people who don't. But I think that's a weak assumption. And if you look at what I think is the largest trial of the underlying etiology of community-acquired pneumonia, the EPIC trial conducted in the US, where they took a large number of people who met a gold standard radiological definition of community-acquired pneumonia presenting to hospital, they found that the dominant pathogen spectrum across all these people were lower respiratory tract viruses. The most common pathogen detected of all was rhinovirus. Then you've got flu and parainfluenza and COVID and human metapneumovirus. These are pathogens that previously we'd assumed led to a non-pneumonic presentation. The BTS say when you get to hospital and you're a physician like myself or an A&E doctor and you want to invoke the diagnosis of community-acquired pneumonia, that you should be looking for radiological evidence, so changes on an X-ray. Is that being done? Is that how physicians practice? Well, if you look at the BTS audit for community-acquired pneumonia, they started with 40,000 cases from the UK of patients who had been coded as having been managed for community-acquired pneumonia in UK practice. They asked clinical centres to review those cases, to validate them, and return the clinical characteristics of those patients. 20,000 cases were clinically validated, and half of them, at the beginning, were excluded for not meeting a case definition of pneumonia. Why were they excluded? Well, the single most common reason for not meeting a definition of pneumonia was lack of radiological infiltrate. So we have these sacred cows of what definitions of pneumonia look like, but clinicians are not using them. They're not using them in primary care, and we're certainly not abiding by it in hospital practice. We want to code people as pneumonia, we want to treat them as pneumonia, but we're not relying on this business of a chest X-ray. And these things are important because our guidelines and the management within them are based on literature and evidence that revolves around these case-based definitions. So that's just pneumonia per se. We have weak underlying concept and agreement of what it is. When we get into the subdivisions of hospital and community-acquired pneumonia, things get even more muddled. I think the reason we've ended up with a definition of hospital-acquired pneumonia as being separate to community-acquired pneumonia is because the assumption is that 48 hours after your admission to hospital, if you develop pneumonia, you're much more likely to have the underlying etiological agent be some kind of enteric gram-negative organism, and that's much less frequent in the context of community-acquired pneumonia. This group did a point prevalence survey of the frequency of gram-negative enteric organisms in the context of people presenting with community-acquired pneumonia across the world, so in the US and in South American countries and Europe, etc. And they found, A, that on average there were far more people with gram-negative enteric organisms in the context of CAP than they previously thought, but that the rates varied wildly across centres. So even within Europe, if you were to practice as per the European Respiratory Society guidelines for community-acquired pneumonia, you would find that in different countries, your guidelines are more or less likely to be applicable and to lead to appropriate management. So wildly different rates of Enterobacteriaceae between France, Europe, Germany in particular, with 3 times the rates in the UK. And when you get out to Africa and South America, some of these rates are exceedingly high and associated with high rates of antimicrobial resistance. Even within a country, if you believe that a community-acquired pneumonia guideline captures a consistent set of etiological agents to be managed appropriately by your guideline recommendations, that will be a flawed assumption. So the Australian community-acquired pneumonia guidelines look very much like our standard British community-acquired pneumonia guidelines. But if you take them to a major metropolitan centre in the Northern Territory of Australia, Darwin, and look at what their pathogens are over consistent audits over years, you find that, okay, strep pneumo represents 9% of all people who present with CAP and is the most commonly identified organism. But in this one-year audit, they found that Burkholderia pseudomalaei, so the cause of melioidosis, a pseudomonas-like organism that's unlikely to be treated by a standard CAP guideline, is at least as common. And looking back over 10 years, they found that it represents 24% of all their CAP diagnoses with a very high associated mortality. So even within a single country, assumptions for a standard CAP guideline fall down in different regions. If you take a CAP case definition and translate it to Southern Africa, like this group did in Malawi, you find that people who meet a community-acquired pneumonia case-based definition have Streptococcus pneumonia identified very frequently, but more commonly, this case definition captures people with TB. There are more muddles associated with our definitions of HAP and CAP that go beyond geographical variations and assumptions about the underlying pathogens. The BTS guideline for the management of community-acquired pneumonia says that people who present to hospital who've been in hospital within the last 10 days are out of scope because they might have hospital-acquired pneumonia and should be treated as such. The more recent NICE guidelines for the management of hospital-acquired pneumonia say that if you diagnose hospital-acquired pneumonia between day 3 and 5, that we'd quite like you to treat them as per the community-acquired pneumonia guidelines. So what you have here is people with CAP being treated as HAP and people with HAP are being treated as CAP. And what that leads to is complete disarray in the A&E and people not knowing what they're doing and not knowing which guideline they should follow. And if you don't believe that, here's some data from we have an ongoing surveillance project looking at the quality of care that we deliver to people with hospital-acquired pneumonia across the Northwest. So we have 18 participating trusts who are consistently returning cases of hospital-acquired pneumonia, and we're describing the patient characteristics. And this single bit of data asks the teams to go back into the notes and say, on which day of a patient's admission was the diagnosis of hospital-acquired pneumonia made? And the single most common day, consistently across all trusts, for a diagnosis of HAP to be made is day 0. So the day that a patient presents to hospital. So HAP is a diagnosis made in A&E at the front door. I won't labour this point, but another issue with all our guidelines is they have a huge number of exclusions. So the community-acquired pneumonia guidelines, amongst other things, say that people who present with a systemic disease-induced immune suppression are out of scope. So that's all our people with rheumatoid arthritis, with inflammatory bowel disease, with underlying hematological malignancies, with renal disease. This is a very large proportion of the people who develop CAP who present on the acute take. So not only have we got, I think, dodgy definitions and assumptions about what pneumonia is and what its subdivisions are, but we base our risk stratification tools on those case-based definitions. And I therefore think our risk stratification tools are hampered and are imprecise and are of limited practical use. What's the evidence of that? Well, a new virus comes along that causes pneumonia, and you find that our old tools completely fall apart. So the CURB-65 score is nationally mandated to be completed in people who present to hospital with CAP, and we're meant to manage people on that basis. People with a CURB-65 score of less than 2, so 0 or 1, prior to the pandemic, were assumed to have an all-cause mortality at 30 days of 3.3%. And that meant that we were encouraged to discharge these people at the point of presentation because they were low risk. And what we found in the first wave of COVID is that if you apply a standard catch-all community-acquired pneumonia definition to this virus, 16% of people die in the lowest risk stratification bracket. And so if you send all those people home, you get struck off. But we previously conceptualized pneumonia, I think, in many people's minds, as virus is less severe, bacteria are the bad guys. That's why we're so keen to give antibiotics. If you look at the CAPNET data, which is a huge ongoing cohort study of people with community-acquired pneumonia in Germany, they compared one particular form of bacterial pneumonia, so mycoplasma pneumonia, to all other bacterial cases of pneumonia. So you've got the mycoplasma here in this column and the data for other bacterial pneumonias in the first column. And you can see that mycoplasma pneumonia is a very different clinical presentation to the others. It generally occurs in people of younger age. It has a lower systemic inflammatory response, so people presenting with a median CRP of 60 as opposed to 173. Most people are, when they present with mycoplasmal pneumonia, are in the lowest bracket of risk stratification, so 72% of people in the CRB 0 or 1 bracket, as opposed to 33% of people with other bacterial pneumonias. And that's borne out in the mortality data, where less than 1% of people with mycoplasma pneumonia died, and up to 9% of people with other bacterial causes of their pneumonia died. So here you've got a bacterial etiological agent causing CAP with relatively low risk, and I've just shown you a viral cause of CAP with relatively high risk, and in both situations, our general assumptions about all-cause risk in community-acquired pneumonia fall down. So to summarize, how I've tried to disrupt things is by saying that our current conception of what pneumonia is weak. We don't agree, we don't apply the case-based definitions, it's the Wild West. The etiological agents that cause CAP and HAP and non-pneumonic lower respiratory tract infections overlap enormously. And the more tests we do, the more we will have to grasp that nettle, and we'll be faced with that. Our current definitions have really limited geographical scope, in some instances even within a country, but certainly within regions. And they exclude huge numbers of people who we have to come up with a system to manage. And the longer that we continue to manage people as per these syndromic case-based definitions, the more we have to accept that we will give inappropriate management. Some people will be over-treated, and a large number of people will have inappropriate under-treatment for their cause. And we're going to really struggle to develop adjunctive therapies, which are going to be really important for people with pneumonia. So what do we need to do? I think we need to reevaluate our concepts of lower respiratory tract infection, and we need to really focus that on the underlying etiology. But that's inevitably going to lead us to develop new pathogen-specific management algorithms. Already in A&E, you have some people who are managed as per a CAP guideline, but other people who have CAP, but it's caused by SARS, that go down a SARS guideline. And then in flu, we have people who are managed by, who've got pneumonia, but managed by a flu guideline. But as we roll out these new technologies, are we going to have a Pseudomonas pneumonia guideline, and a Moraxella guideline, and an RSV guideline? And we're going to end up with a lot of guidelines. The benefit of going down a pathogen-specific route is that it's enabled us to really dig down into the pathophysiology of underlying pathogens. So in COVID now, when you come in, not only do you get a pathogen-targeted antimicrobial therapy in the form of antivirals, but some people also get specific anti-inflammatory therapies and specific anti-immune therapies that are targeted on a particular pathophysiology associated with that particular pathogen. And the more that we learn about individual pathogens, the more those adjunctive therapies will be able to be developed, but the more complex our algorithms will be. And the two key challenges that I will leave you with, as exciting as these new technologies are, they will fall down if we don't have a clinical specimen to use with the kit. And very few people currently with community and hospital-acquired pneumonia produce a sputum sample. And then we have to think about the complexity, as I've said, about these myriad different management pathways and how we can implement new computer technologies to help us put people down the right path in the future. So I'll leave you with that, hopefully provocative talk, and ask you to reflect on World Pneumonia Day. Thanks very much.
If we assume you're right, and I personally believe you're absolutely right, our definitions are stilted, and they're fixed, and they're sometimes crazy, and I'm not a guidelines person. The real issue is that if you then throw in the antimicrobial stewardship drive, you're going to end up with a whole bunch of immunosuppressed people who don't really fit, who are, and somebody will say, oh, no, you should be giving amoxicillin for this one, sort of thing. And I don't know whether it's people's experience. Certainly, we've come across patients who, for the sake of have fallen, if you want, on the antimicrobial stewardship police sword, and probably inappropriately so for lack of a diagnosis. And 4 days later, that's the point you realise that they got the wrong stuff. And does that ring any bells with any of you? Do you think that we can leave things as they are? As all of us get older and more decrepit and on more immunosuppression and on more steroids and more with living longer with chronic disease. I mean, I'm personally completely with you. I suspect nobody's going to argue with that. Would anybody have any comments? Don't all speak at once. Yeah.
Well, thanks very much for your talk, Dan.
Can you hear me? Yeah. When you discussed the BTS data, you said more than half the cases were discarded because their chest X-ray didn't show any consolidation, and that was from 2018. Commonly, patients get CTPAs for almost no reason, and instinctively we rally against this. But maybe a CT would be useful in the early diagnosis of pneumonia, because I don't think you're arguing we should discount the idea that pneumonia is a parenchymal lung disease that can be detected by imaging. I think you're saying that we don't use it properly. So maybe rather than fighting against CTs that are routinely done for slightly the wrong reason, we should do CTs to diagnose pneumonia in hospitalized patients. Well, that was the question.
Thanks a lot for your question. So I'm with you. I think we should certainly explore the benefit of CT scans. I mean, the literature, the pneumonia literature has quite an active discussion at the moment about the benefit of early CT scan. There's a very widely discussed paper by a group led by Claessens et al. In Belgium, who looked at the value of early CT scan, and they demonstrated that in the context of community-acquired pneumonia, an early CT scan led to a very frequent change in clinicians' management. So patients had an X-ray first, the clinician was asked to make a management strategy, then they had a CT scan, and the clinician was asked whether they wanted to revise their strategy, and very frequently it led to a revised strategy, and the overall outcome of that was a reduction in the amount of antibiotic that was prescribed, because overall fewer people were felt to have pneumonia. I am attracted to that, and certainly as a chest physician, I agree that CT scans are simply a more powerful tool at looking at what's going on at the parenchymal level in the lung. However, I'm not convinced at all that anyone's shown any evidence that if we suddenly switched overnight to using CT scans instead of chest X-rays, that would make any difference at all. Studies have shown that CTs are better than X-rays. I don't think that's controversial. It's simply it's a more powerful microscope, right? You see the lung better. But I don't think that's necessarily going to lead to a change in clinician behavior. I don't think it's going to lead to changes in outcomes that matter to patients, reduced mortality, reduced length of stay, reduced antimicrobial prescribing. It might, but I think we need trials to do that. As it happens, I'm about to run one, so look out for it. It's a trial where people will be randomized to chest X-ray or CT and followed up to see how it influences their care, the HAP FAST trial. It'll start recruitment in February. But to go back, I mean, you made a provocative statement to say that people get CTPAs for almost anything. I disagree with that. I don't think our colleagues are idiots. I think when they see people and they're struggling to make a diagnosis and they are pressured with litigious cases where people are discharged or found to have venous thromboembolism that was missed, I think if you were to do some sessions in A&E and been confronted by the numbers, I think you would do more CTPAs than maybe you think. So I don't think they've been done for no reason. And of course, in COVID, we found that many more people have underlying thromboembolic disease associated with respiratory tract infection than we thought. I think that's always been the case, and I'm not sure we know whether all of those matter, whether a tiny subsegmental PE actually makes a difference or not. But I'm reluctant to criticize people for ordering tests that may be beneficial without good evidence to the contrary.
Thank you very much. I could, any other questions? Yes, please. I think there's more of this one. I'll hold this.
Thanks very much. So Tristan Clark, infectious diseases physician from Southampton. Thank you very much for your talk. I agree with almost everything you said, but not all of it.
Okay.
So my point was, you made a comment about the reason that we hive off pneumonia as a separate entity, and you seem to suggest that this was based on this acknowledgement or this this presumption that there's a separate etiology. But of course, I think it's a lot more than that. So the reason, community-acquired pneumonia is a separate entity is historical, but it's the recognition that it has a different clinical course and different clinical outcomes. And I suppose if you're suggesting that we lump non-pneumonic lower respiratory tract infections with pneumonia, I guess without knowing completely what the clinical course and the need for antibiotics and the outcomes are, does that not risk undermining effective treatment of something that we know is dangerous and high risk? Over.
Definitely it does, and I'm not suggesting we should do that. What I'm suggesting is that we are doing that. What I'm suggesting is that currently we have concepts about what pneumonia is and isn't, and they're defined in guidelines, and you and I will have our own concepts of what pneumonia is and when it's community-acquired and when it's hospital-acquired. What I'm saying is that in current clinical practice, all the evidence suggests that those definitions are not being applied. And that half of all people who are managed as community-acquired pneumonia don't have evidence of pneumonic infiltrate in their lung. Now, I'm not suggesting that we should throw everything apart and it should just be the Wild West and everyone should just get antibiotics as per whim at the moment. What I'm suggesting is that we're in a situation where we're simply not abiding by the case definitions that we've currently set up. We're not doing it. We're not doing it in primary care, and we're not doing it in secondary care. And we've slightly ignored that, I think. But as these new technologies get rolled out, and I'm sure they will because they're very attractive, and we see more frequently what the pathogens are that are causing people's clinical presentations, we're going to have to reevaluate the boxes that we put people in, is what I'm thinking. I'm not sure how we do that and how we implement it. I'm simply saying that at the moment I think we're in a mess, and there's only so long we're going to be able to ignore it.
I agree we're in a mess.
Okay.
Sure.
I'm Michael Murphy. I'm a microbiologist. So I actually wanted to ask, so I wasn't sure whether you were suggesting that gram-negatives are more frequently encountered in community-acquired pneumonia than we think. But in microbiology practice, we frequently find out gram-negatives from patient samples from the community as not significant, or we presume them to be not significant in a patient who doesn't have underlying lung disease and think do nothing about them. So I was wondering, have there been any studies of the outcomes in patients whose treatment does not cover the gram-negative that has been isolated versus those in which it is? Because obviously, sometimes amoxicillin or doxycycline will cover. But do we know if there's a difference between those outcomes which would support that these gram-negatives may be more important than we had previously thought in community-acquired infection?
Do you mean, are they real? Are they really the underlying cause of pneumonia?
The comment that says kind of, this is rubbish, is frequently the...
I'm sure in some cases they are rubbish, and I'm sure in some cases they just represent what's going on in the mouth as opposed to the lower airway. To the best of my knowledge, I won't tell fibs, I don't know. I'd have to go away and look up whether there are actual outcome studies that demonstrate if you have a gram-negative enteric organism that's suggested as being the cause of your pneumonia, and yet you don't receive appropriate treatment for that, do you do any worse? I don't know. I'll have to go away and look that up.
Maybe definitely.
Just to comment on that, isn't it a little bit concerning that we're doing things but for which there really isn't any evidence? And I mean, I'm not aware of that. I mean, that's a great study. Somebody should do it, but it seems to me that a lot of pneumonia treatment, and especially deciding whether an organism is significant or not, is pure guesswork.
Oh, Vicky, that's not provocative at all. Just on that, very interesting discussion about clinical negligence, because in fact I'm involved in exactly a case like that. Where, was a CTPA done, should it have been done, and what happened afterwards. The point about that is that if you end up in casualty and you're a bit hypoxic, and you're in your 60s and you've got comorbidities, somebody may be quite keen, actually, to put you through a CTPA, because the CT itself is low dose, but they're a risk, but I agree, everybody gets one. But of course, D-dimer goes up in 85% of people with community-acquired pneumonia. So you end up in a kind of interesting situation. And I suppose you get closer to the truth, don't you? And by the truth, I mean you have a diagnostic that's better than the previous generation of diagnostic, which is a chest X-ray. And therefore, that should be a good thing, shouldn't it?
I don't want to confuse... I mean, all CTs are not the same, of course. And a low-dose thoracic CT, which would be perfectly adequate for making a parenchymal diagnosis, has someone got pneumonia or not, is very different to a CTPA. Yeah. Giving people lots of contrast and threatening their kidneys, etc., is a different beast. And I certainly don't want people to go away thinking that I'm advocating for lots more people to have CTPAs. In the CTPA discussion, all I'm saying is I am reluctant to be too critical of junior doctors who are ordering CTPAs in sick hypoxic patients with unilateral pleuritic chest pain who present in A&E, because I find that, I'm a wonderful consultant physician, I find that diagnosis very difficult. The issue about low-dose thoracic CTs and whether they are better and will lead to better patient outcomes than chest X-rays, which are ambiguous, and there is lots of subjectivity about their interpretation. I think that's a really valuable question, and my instinct is that we should probably be doing more low-dose thoracic CTs, but hopefully the trials will tell us the answer.
Thank you very much, Dan. Okay,